Assalamualaikum. Today I will discuss about bronchiectasis. At first we know the definition of bronchiectasis, then history, what history we would like to take from a bronchiectasis patient, then differential diagnosis, commonest site of bronchiectasis, occurrence, presentation, dry bronchiectasis, causes, types of bronchiectasis, characteristics of sputum, complication, investigation, treatment. Then we know if a patient with bronchiectasis develops nephrotic syndrome, what will be likely the diagnosis, what is the role of CT scan in diagnosis of bronchiectasis. Bronchiectasis is a disorder in which destruction of smooth muscle and elastic muscle by chronic necrotizing infection leads to permanent dilatation of bronchi and bronchioles. This is normal bronchi. This is dilated bronchi. Here, permanent dilatation of bronchi and bronchioles, loss of cilia, mucus accumulation, destruction of smooth muscle and elastic tissue. Now, what history you would like to take from a bronchiectasis patient? History of cough with profuse expectoration of sputum, which is more marked in the morning after waking up from sleep. Now we know what is the differential diagnosis of a bronchiectasis. If unilateral, a resolution stage of pneumonia, lung abscess. If bilateral, diffuse parenchymal lung disease, chronic pulmonary edema. Why not diffuse parenchymal lung disease? Because why it is not? If anyone question you that why it is not diffuse parenchymal lung disease, in diffuse parenchymal lung disease there is a bilateral basal crepitation, unaltered coughing, and may or may not be present cough with profuse expectoration of sputum. Why not chronic pulmonary edema? Because in chronic pulmonary edema there is absence of cyanosis, clubbing, and and crepitation is fine in chronic pulmonary edema. Now, what is the commonest side of bronchiectasis? Left lower lobe and lingula. Presentation. Patient present with cough with profuse expectoration of sputum marked in morning after waking up from sleep, occasionally hemoptysis and breathlessness. Halitosis occurs here, weight loss occurs, fever, then coughing may be found. Now we know what is dry bronchiectasis. This is a type of bronchiectasis in which dry cough is associated with intermittent episode of hemoptysis. It may be massive, even life-threatening. Bleeding occurs from bronchial vessel, common in tuberculosis patient, usually in upper lobe. This is also called bronchiectasis sicca. Now we know what is the causes of bronchiectasis. Congenital and acquired. Congenital is cystic fibrosis, Carter-Giner syndrome. There is a triad. One is bronchiectasis, second is dextrocardia, third is sinusitis. This triad occurs in Carter-Giner syndrome. Then primary ciliary dyskinesia, immotile cilia occurs here. Then hypogammaglobulinemia, immunoglobulin G and immunoglobulin A causes infection, then it is causes bronchiectasis. Yellow nail syndrome. Here nail is yellow, thick, onycholysis, then leg edema occur here, and pleural effusion and bronchiectasis occur in yellow nail syndrome. Young syndrome, obstructive azoospermia occurs here. Then sequestrate segment of lung. In acquired causes, in children, pneumonia complicating measles, whooping cough, pulmonary tuberculosis. Then in adult, pulmonary tuberculosis, pneumonia. Allergic bronchopulmonary aspergillosis is also a cause of bronchiectasis. Now, what is the characteristics of sputum? Upper frothy layer, middle thick layer, lower segment, epithelial debris and bacteria. We know the types of bronchiectasis. It has three types. One is cylindrical, varicose and cystic. This is normal bronchi or bronchiole. This is cylindrical, varicose and cystic. The complication of bronchiectasis: secondary infection caused by Staphylococcus, Haemophilus, influenza or Pseudomonas bacteria, lung abscess, massive hemoptysis. Hemoptysis is one of the most important complications of bronchiectasis. Pleural effusion, empyema, pulmonary hypertension and core pulmonary. respiratory failure, amyloidosis, brain abscess, aspergilloma. What investigation we should done in a bronchiectasis patient? Chest X-ray, posterior anterior view, ring with shows ring with clear center, honeycomb appearance, ring with or without fluid level, linear streak, trim line. Trim line is parallel line and ring with clear center. This is like it is like this shape. Then high resolution CT scan, it is a definitive investigation. Then CBC, X-ray, ESR, CBC, ESR, X-ray, posterior nasal sinus to diagnose Carter-Giner syndrome, lung function test, sputum, gram staining, cultural sensitivity, acid fast bacilli to diagnose tuberculosis, bronchoscopy, serum immunoglobulin to diagnose hypergammaglobulinemia. X-ray posterior nasal sinus because Carter-Giner syndrome. Carter-Giner syndrome included consists of three. This is called tired. One is bronchiectasis, sinusitis, dextrocardia. Then we know the treatment of bronchiectasis. What treatment we should done in bronchiectasis patient? Postural drainage. Here affected part is kept in up, then percuss the area for 5 to 10 minutes. Then chest physiotherapy is the most definitive treatment in bronchiectasis patient. Daily airway clearance therapy. If this treatment is applied and patient is not recovered, then surgery, lobectomy can be. Then if patient with bronchiectasis develops nephrotic syndrome, what is likely the diagnosis? Amyloidosis, proteinuria. We investigate by proteinuria. Splenomegaly may be found. What is the role of CT scan in diagnosis of bronchiectasis? CT scan is 60 to 80% sensitive, but high resolution CT scan is 90% sensitive. CT scan is 10 millimeter thick, but high resolution CT scan is 1 to 2 millimeter thick. There is a vicious cycle: inflammation, permanent airway dilatation, loss of cilia, mucus accumulation, infection. Assalamu alaikum.